Hello and welcome to the February 2021 Pre-Hospital Care Research Forum Education Research Journal Club podcast. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. The PCRF partners with the National Association of EMS Educators to promote research literacy and advance the science of EMS educational research. Here with the PCRF Journal Club, we take a closer look at some of the latest happening in medical education. Now, I'm Megan Corey, by the way, and I'm going to be here with David Page. Hopefully, Dr. Bill Toon will join us. We have Katie O'Connor from UCLA. We're going to have Alex Tremblay join us from North Ambulance Service in Minneapolis. We've got a nice group, and I'm sure we have a great group of educators out there. The study we're going to be reviewing today is called Student Experiences of a Paramedic Clinical Facilitator Model During Ambulance Clinical Placements, a Qualitative study. So this is a study that's in press that comes out of Australia, where, by the way, it is currently 5 a.m. and we have a wonderful person who happened to join us at 5 a.m., which is one of the study authors, Liam Langford. So we want to thank him for rising early and joining us today. But first, we do have some news to go through before we dive into the study, and that is we want to remind everyone that we have an upcoming call for abstracts. Each year, the call for abstracts highlights the pre-hospital care research forum activities. As you know, the abstracts are received from EMS providers, from educators, clinicians, and students from all over the nation and abroad. So it's a peer-reviewed process. It determines which authors are going to be invited to present their studies at a national and sometimes an international conference. So this call for abstracts, it's education, it's combined. So it's education, clinical, and systems abstracts deadline all together June 30th, 2021. Don't miss out on it. You're going to submit your abstract online. For more information, you can email pcrf@mednet.ucla.edu. So important stuff. Don't forget to get in there, collect your data, start crunching those numbers, start thinking about what things you can put together to contribute to our body of literature here. So thank you all for joining us today. Let's begin. We want to remind listeners that you can use the chat feature on your screen to type in questions and comments. We'll bring those into the conversation as we go. And if you have something maybe a little longer to discuss, you can send a message to the coordinator here and we can come into the conversation live. So thanks everyone for joining us. We have a great topic today. Paramedic education, we know, involves several phases, and the typical sequencing, and we're talking about, paramedic education in general, no matter where, but we know in the US, usually we have a typical sequencing where classroom and didactic and lab are at the beginning of the program. Sometimes a program might have some clinical or field experience time, but accredited paramedic programs in the United States will have a capstone field internship that takes place at the end of the program after the didactic lab and clinical competencies have been met. So paramedic field internships use a preceptorship model whereby the student intern is placed in an operational setting with a preceptor. Sometimes it's the same person, and other programs they might have different preceptors during the internship. And that preceptor has received some type of orientation or training by the program, sometimes by the employer, in teaching methods in a field or clinical setting, like providing feedback and evaluating student competency, these types of things. And that's part of the accreditation standards for US accredited programs. Now, nursing, on the other hand, typically uses more of a facilitator model where a member of the faculty is assigned as a part of their instructional assignment to a small cohort of students as a clinical instructor. It's more of an educational model as compared to the preceptorship, which has more of an operational emphasis with some education components in it. So this study is out of Australia, and we know we've talked about to some Australian researchers on this podcast. So we know that the paramedic education in Australia is an undergraduate degree program. So it turns out this area, though, this internship and experience in the field has some similar struggles as we do in US programs. So I want to just go right to it and bring in the author here. So first of all, Liam Langford, thank you for getting up at the crack of dawn and in Australia and joining us on this. I'd like you to introduce yourself and just tell us how you came to study this topic.
Yeah, no problems. Well, thank you very much for having me on board for the podcast. It's an absolute delight. You mentioned the crack of dawn. It hasn't even cracked yet. It's still dark, which is quite nice because then they'll get to experience what it's like being on a night shift. And then looking forward to crawling back into bed afterwards and having a nap. But no, thank you very much. So a little background about myself. I've been a paramedic for about 10, 12 years now, and I'm based in the Australian Capital Territory. And that's kind of like your equivalent to Washington, DC. It's like a government town. With that, I also used to work for a larger metropolitan area up in Queensland, and then also up in the rural area, the Daintree, Port Douglas, near the Great Barrier Reef. So I've had great experiences being around the country doing paramedicine, but I moved into the higher education space probably about 7 years ago. As a secondment. There was a relationship with the ambulance service I worked for, and then the university doing the undergraduate program, and had the privilege of doing a secondment year teaching with that, and that really kind of set me on my path to the kind of academic space of paramedicine with that.
So is this research then part of your studies itself, your advanced studies, or do you just enjoy research?
It's funny because I don't know, I think in the world of academia, you're always looking out for opportunities and grants and things that kind of make a bit easier. So there's an author on this paper by the name of Shane Lenson. He was the lecturer at the university I got seconded to, and he was the one actually who was able to secure a grant funding. It was part of like a regional innovations grant. So he got a reasonable amount of money. And what occurred, he was able to, because I had master's background by then as well, he was able to employ me as a researcher once my time as a secondment was up. It really actually extended my secondments, but it moved me from a teaching focus into a research focus, where, we basically implemented this trial over about 3-month period, and then kind of led the research from then on, and that's how we kind of came to the paper and my involvement in it.
So I have the objective up on the screen for those of you who have access to a screen in the slides. But the objective of the study, again, is describing experience of a clinical facilitator model. So the one we just mentioned about nursing using a clinical facilitator model, this is being used in this study for paramedic students during their what is called your clinical placements. And I think at some point we'll probably clarify where that what the progression of a paramedic student is and at what point are we talking in terms of this clinical facilitator model. But in the meantime, I'm going to switch over. This is the objective of the study. I'm going to switch over to this table, which is going to stay up here so we can make sure that we distinguish between the two characteristics here of preceptor versus facilitator. But can you just back up and describe, if I'm a typical paramedic student in Australia, at what point are we talking about that you're implementing this study?
Yeah, no worries. With Paramedicine Australia, it's not directly related to employment, so the undergraduate training. You have to do the training or the undergraduate degree and then apply for an ambulance service. So it's not like some colleges or other undergraduates around the world where it's almost you guaranteed employment once you're in the door. It's you do your undergraduate first, and then if a job's available, then you go into it. So the typical degree in Australia is about 3 years. There's some 4-year programs, and then there's also some dual degrees around, so nursing paramedicine dual degree or a paramedicine public health dual degree as well. So what usually occurs is they spend a semester doing about 4 subjects, and those 4 subjects range from social determinants, ethics, and then your pathophysiology or biological sciences and pharmacology, and then also your paramedicine subjects. And then, yeah, that's where you do your kind of practical skills and simulations or scenarios. And then typically at the end of the semester, a student will go out for between 2 and 6 weeks to have an experience with a clinical placement environment. And that clinical placement environment doesn't have to be in an ambulance service. We also place students in the emergency department, GP clinics, maternity, to get a rounded experience and interdisciplinary experience. But what we're focusing on is that actual traditional ambulance-based experience when they go out. And when they go out for their ambulance experience, because ambulance services are operational, they've got rosters, they've got particular stations and short staffing and things like that. Students usually just get assigned a station and rock up, and then whoever the paramedic is on that day kind of picks up the students and takes them out. Some areas are quite lucky where they might get assigned a preceptor, and that preceptor is with them for a period of time, be it that 2 to 6 weeks, or other times it's just whoever is on station and they roll the dice with the preceptor. So it's a bit of a kind of fluid model and depends on the system and the context.
Yeah, that's similar here. And you know, Dave and I are both site visitors for our accreditation, and that was one of the things I noticed when I started doing site visits around the country, is how different the models are in terms of when students are put into a clinical setting, including a field, what we call a field experience setting, which is what I think what you're talking about, versus you know, when they go to also, when they go to the capstone, we have a capstone field internship. So all the competencies have to be met, and then they go into a capstone phase. And some programs around the country will have some degree of field experience before then. So the capstone phase, by the time they get there, they've had a little bit of, you know, orientation to the field, all that kind of, you know, mystery of the field is you know, handled early on, and then during the capstone phase they demonstrate competency. But a similar thing, different programs will do it. You know, some will have one preceptor versus, you know, a couple of assigned preceptors, and other programs I've seen it's whoever is on shift. And you know, there's been some research I know that shows that the fewer preceptors are associated with better outcomes. At least here, you know, we've seen that. But yeah, it's interesting. So do you have a capstone experience then too, at the sort of end of the program before they get their degree?
No, not necessarily. That capstone, once again, becomes between either 2 and 6 weeks. And that's just based on the availability of placements. Paramedicine in the undergraduate space went through a big boom, and the number of students increased, but the number of placements didn't. So a lot of new players into the undergraduate space, or existing players, had to kind of reduce the number of hours of placement, and the capstone is usually the internship once they get employment. So they get through undergraduate with doing probably a total of, say, between 300 hours to up to 800 hours, depending which university, of clinical experience or field experience you guys mentioned there. And then once they graduate, they become registered. Then they go on to do an internship, and that internship, once they're employed, is more of that capstone. So it's between 12 months to 18 months. So it's a long road for some students, where you're saying 3 years undergraduates, and then probably another 18 months on top. So it's 4.5 years before you're an independent practitioner, which obviously you want, because paramedicine is actually a very dangerous job, both to the public and then also to yourself. So you want to make sure there's rigor associated with that. So that's why we're in this kind of 4-year model in Australia.
That's great. Thanks for that background. I think it's really important that the listeners get some context about what environment the study is based in. Dave or Katie, do you guys have any questions in terms of sort of setting the the stage for the study.
I think it's fascinating. Thank you for being on with us. Liam, it's just really refreshing to hear all of the advances that Australia has done. And I always find it fascinating when you look at the new registration scheme, your entire curriculum, if you will, or guidance on standards is really a domain-based standard and doesn't really actually say they have to have on-road or hospital placements. It's left up to the individual institution to decide the amount and quality or location of these placements. Is that correct, or do you have guidance? Go ahead.
That's perfectly correct there. The accreditation model here is an outcomes model where we have to show that the students meet, like you said, domains or capabilities, and those domains range from being an evidence-based practitioner, so incorporating evidence into your daily practice, to being ethical. Another domain is the kind of social skills, or some people call them the non-technical or soft skills. And then another domain is about, say, working with interdisciplinary teams and stuff like that. So it's not your traditional, like, you must do this many cannulas to meet this, and you must see X, Y, Z conditions before we kind of sign you off. That's old competency side of stuff. It's more domains, and they've got these capabilities per domain. And we have to show that the curriculum demonstrates to the accreditation body that the students meet all those domains within a clinical setting. And that clinical setting is a nice broad term. It can be from these traditional field placements to a simulation, or high quality simulation, where you can actually target those particular capabilities, to those more diverse placements or non-traditional, where they are with community paramedicine, GP clinics, EDs, things like that.
And universities that struggle could actually just only do simulation. It's really dependent on the educator to decide, correct?
Yeah, definitely. It's about if you can demonstrate that a paramedic student can meet all those capabilities within a simulation and can justify that, that should suffice the accreditation standards. It hasn't been tested yet because those accreditation standards are recently new, as in within the last 6 months, because we've just gone through a nationalisation of one, registration, and then two, the accreditation authority falls under that national registration. So it's only fresh in Australia. So we're, as a collective of paramedic academics around the country, is still getting our heads around it, and a lot of people are saying, how many hours of placement do you need? And the accreditation board comes back is, as long as you can justify what you're doing meets the capabilities. So it can be a little frustrating in some areas because you don't have that nice clear delineation, but also it allows for innovation and research, and I think that's the kind of great purpose. So if you're coming back to your example there about, could you do a whole degree based on simulation, it's like, well, there's a great research grant, that's a hole in the literature, let's see if we can do that. And if it proves that you can, or partially can, that just adds an extra tool to paramedic education, both in Australia and around the world.
Love it, love it, love it.
That's great. I'd like to get into the research question here too. So now, what took you to this question about the, comparing a preceptor versus a facilitator model? You mentioned earlier you have dual degree programs. You have paramedic RN or nursing programs, paramedic public health, dual degrees. Did it come from this comparison between, or does this, why this subject?
I think it came out of the kind of nursing experience. So within the university I work with, paramedicine sits under the School of Nursing, Midwifery and Paramedicine, and nursing is the largest program within the university that I'm with. So we're kind of constantly exposed to those conversations around clinical placement, and everyone was talking about these facilitators. And Shane, who secured the grant on this paper, he's from a nurse background and a nurse practitioner background as well. So he's experienced with that kind of nursing education, and he and the deputy head of school at the time basically came up with the idea. It's like, hey, we know there's these particular issues, which we'll probably get to around clinical placement for paramedic students. Could we replicate that model of a facilitator for paramedics on road? So that was the kind of back history where it came to.
And for those who can't see the screen right now, the table 1 in this article, and I have to say I really enjoyed reading this article, especially the introduction and how you discussed the background of what kind of, I can't remember the name of it, but it's it's a quality, it's the Health Workforce Australia is where this comes from, right? This is the, well, actually there were quality indicators earlier too, indicators that I think it was a commission by the Health Workforce Australia that talked about factors that will improve your clinical experience and factors that might hinder a clinical experience, which I thought was interesting because I thought that kind of set the stage for this. But just looking at this table, the comparison of what do we mean, in case there are people out there listening and say, what's a difference? A facilitator or a preceptor is just a term, but actually there's quite a difference. So if you look at the preceptor, this is an operational, they are on day-to-day operations. They're typically employed by the employer, by one of your industry advisors. We have advisory committees here that inform programs. They're staffed, part of normal staffing levels, as it says in the table. They're working their regular job, and their emphasis is really, I really like this, policy, culture, and guidelines. So it really is kind of what's happening around them. And they supervise individual students, and they focus on their own, basically they're coming from their own clinical background, their expertise as a paramedic. Whereas a facilitator is actually focused on the education of it's a student-teacher relationship. It's much more about that critical self-reflection and the loop back of learning, teaching and learning. Oftentimes the facilitator has a smaller cohort. They're employed by the college or university. So they have a focus on the pedagogy, not on the operational aspects. So I think that's a real difference, even though they do tend to be a lot, I know in nursing, they tend to be commonly employed at a hospital and employed at the university. And I don't know how it is in Australia, but that tends to be how it is here. But they also, in this role, they are an educator. Versus as in a preceptor role, they're actually on staff, and this person is, what do you want to call it, riding along, quote unquote. So it's a little bit different. So you wanted to compare this. Now, tell me, so you have your research objective. How did you go about designing this? Because you chose a qualitative approach, I'm assuming because the question asks about what's the experience of the students. So you wanted to focus on the students. You chose a qualitative approach, and then
definitely.
Yeah, and how did you go from that? Did you toss around, well, should we do this in a survey and a quantitative, or should we focus on the qualitative? Why choose qualitative?
With qualitative, I find that you're able to lend context to the why, really get a voice of the participants and their experiences, and then be able to use that rich data to kind of start to aggregate themes or notice patterns that occur, and then build up a kind of evidence base or narrative for what's going on, and it kind of be a bit more storytelling and a bit more humane, because yes, surveys are good and you can show kind of a correlation, but you don't really get into that nitty-gritty of the why, and provides that window into what it's like. And sometimes you can get some really rich explanations or experience of students, and that kind of just summarizes the whole experience for other students as well, but in a nice succinct way with their own voice. So that's kind of why we like the qualitative approach. And we're looking at experiences. We weren't looking at, if we chose, say, a different model like outcomes, to start with. So if we wanted to say outcomes, what are the outcomes of clinical placement, and does the intervention of facilitator increase outcomes, we'd probably go for a more quantitative approach, but we're really looking at the experiences, and that's where a lot of placement research was kind of already based in as well. So we were kind of put in the same context or the same research narrative as part of the previous research looking at paramedic placements or your field placements as well.
I think you said something really important there, and you know, jump in anytime, Dave and Katie, on this. But when it comes to research, a lot of times there's this quantitative focus, right, in medicine. So we have these research, especially now that we have these giant registries of data. We have lots of, you know, data mining and numbers coming out of things. But I think something that illustrates this, what you're talking about trying to get more of the experience, is a number of airway studies we see out there, and it's all about numbers. And then lo and behold, years ago, Henry Wang came up with a study that said, you know, let's just ask focus groups of paramedics, what's their experience with difficult intubation, to pull out the, you know, the experience and the voice of the paramedics, rather than, you know, just saying, you know, what are the factors associated with difficulty intubation, and you measure. He actually sat down with focus groups of people and asked about their experience, so you could get sort of that rich voice and those themes that came out of it. So I think that's a really good point. If you already had quantitative research here that pointed you in a direction, you wanted to take a deeper dive here. So can you tell us then who you studied? How did you go to select the groups that you're going to study?
Yep. So we had a really good stakeholder relationship with the ambulance service here, the Australian Capital Territory Ambulance Service. They have roughly about 200, 300 paramedics running about 12 to 16 ambulances per day, servicing a population of about 400,000 people. So it's a nice, small kind of controlled area, purpose-built city as well. The ambulance service always goes along that they've got the best response times in the country, but also they've also got the best roads. So kind of digress, but I like to point that out. So we got a nice relationship here with the ambulance service, and it's just one ambulance service. Unlike, there's no private providers or anything like that. It's a jurisdictional ambulance service, so it makes it quite easy to engage and build that kind of relationship. So the now chief officer, but previously the general manager, Howard Wren, he was like, yep, I'm happy for this trial to go ahead. So we built that relationship and then worked around how we were going to staff this kind of trial. Do we put people on a casual rotational basis with a facilitator, or do we have one person who's constant throughout the week, who usually works afternoon, so you can cross that day shift, night shift type of thing? And then we went with just the one participant because we wanted, or one facilitator because we wanted to make sure we got that consistency as well. And actually it became a kind of a bit more of action research in that realm, because I'd come on board as the researcher, and they're like, well, you've taught as well and you work for the ambulance service, so you may as well be the facilitator. So I actually end up being the facilitator over that 3-month period with that. So that's the kind of initial conception. It was 3 months. The participants were 2nd to 3rd year dual students. So what I mean by dual students, I mean they're nursing and paramedicine. So they actually already had exposure to the facilitator model in nursing, and was sometimes perplexed when they did their first placement with paramedicine, because they always do nursing placement first. We didn't actually have that facilitator model and being put out there. So and over that time, we had about 50 students go through that clinical placement with exposure to a facilitator, which was about that 3-month period.
Okay, so and it says in the study that you had a total of 74 potential participants. But so tell me about that. You recruited, and it says by email and consent. Well, you invited them by an email and consent form, and then so of those 74 potential participants, did you get? You had 11. Was that correct?
Yeah, we had 11 attend 2 focus groups, so one of 6 and one of 5. And 74, and of those 74, we actually had some graduating students who probably would have been able to be captured because they would have moved on from the program. But yeah, across the 2 cohorts, which were 2nd year and 3rd year students, and we put out, as you say, an email looking for participants, and they had the opportunity of getting a movie voucher, so for their time, just in exchange for their time as well.
Yeah. And was this the pilot period, or did you have a pilot period prior to it?
No,
the publication?
Yeah, this was the kind of pilot period over that kind of 3 months, part of the grant, and then we did the kind of recruitment and the data gathering afterwards.
It's great. I really love it. I put in the chat area for people who are not necessarily watching for that a little bit of how you did this facilitator model. I think we always think of paying somebody extra in the emergency department in the U.S. to be there with the students. That's not part of regular staff, so that they can seek opportunities and have the students reflect on their actions and evaluate them, assess them. But here, your facilitator had a rental car, training equipment. So you were roving, you were moving around, trying to just catch the students on calls or at the hospitals after dropping off a patient. How did that actually, where did you meet up with them?
Yeah, basically I'd work out who was on which station. So there's about 5 stations that students were placed in within about 10 or 15 minutes of each other. So getting around town wasn't too bad from that. And I'd just work out who was at station to start with. So I'd try to start the shift the same time as them so I could kind of be a bit of an icebreaker, because the facilitator, myself, kind of knew all the students, but also knew all the paramedics. So it helps with that in-group, out-group mentality and break that down. So I'd work out who was at particular stations to start with, do that introduction. They would get a job, and sometimes the facilitator would go along with them to the job to observe what's occurring, or move on and find the next student. And really how the next student would be found is you just ring up the communication center and be like, oh, I know such and such is on truck 123. Whereabouts are they? And they're like, oh, they're on their way to hospital. And you're like, all right, I'll go up to hospital and meet them at the emergency department. So you're kind of there in the emergency bay. Student arrives, and then you can observe and give in handovers, triage and handovers onto a bed. And then it's that real crucial time for a good experiential debrief after that, because they've done the full job. So you can get them to kind of do that double back reflective practice of what occurred, how did they feel, what would they do next, type stuff. And then that session would, I guess, conclude. They would get another job. Once again, either you'd cruise with them to get that and observe them on that job or that case, or you'd find the next student and just ring around and say where they are. And it seemed to work pretty well.
Yeah, I love it, and that kind of the sparking and reflection on action has been shown in other research to really improve the clinical reasoning, the critical thinking of the student. I'm curious about just a couple of those details. So you were actually on the job with them. So would you jump in the ambulance and go with them to see the patient, or would you follow the ambulance and then just kind of enter the scene? Was actually that part of your experience with them, or?
Yeah, it was a bit of both. So if it was, say, a code or lights and sirens or whatnot, I couldn't take a rental car behind an ambulance because it didn't have any lights fitted to it. So yeah, you just jump on with them in the job. and then go to the scene. Or say if there's more of a low acuity, just road speed, you just follow in the car and then just rock up on scene, and be that kind of extra person on the hands, on the job with extra hands, just kind of standing back, observing what's going on. And if it was a bigger job, I'd be able to the facilitator is able to step into an operational role if it requires more hands anyway, because they do have experience. So it has a minor operational role, but majority of it's for education.
So Alex Tremblay's on the road here, but he's safely messaging us to ask us.
Hope safely.
To ask what does Liam think of this model with an EMS supervisor that has very similar ability to respond? So in other words, it would be another level of operational, kind of more still someone who's on staff, but an EMS supervisor.
Yeah, so that's a really good question there, Alex. What I envision would be the best way to actually operationalize this is ambulance services basically provide a vehicle, both and like almost an internal facilitator, someone who's kind of purpose trained and purpose identified and has clear roles and responsibilities, and they actually work for the ambulance service, and the ambulance service, depending on the relationship, either charges to have students and provide this facilitator role that still has a operational role and can be be in a response car as well around that, or depending on the relationship, it could be a cost neutral for both of them. So if it was to replicate this again, I would say for access and kind of still having some slight operational role like a supervisor has, I'd say it would be provided, the service of facilitator would actually be provided by an ambulance service in the house.
Yeah, I love it. And I think it's so variable. With a supervisor, they have a set of duties as well. At least in our world, they might get called over to get a complaint, and you're then stuck at a hospital waiting for them to take this complaint or take this call, and they're sort of running around bringing equipment. And it seemed like you had a lot of freedom of movement, where you sacrifice a bit because you're not in a marked emergency vehicle that goes wherever it wants to go, but you can also just basically get what you need done and let the operation of the ambulance service continue on. I'm curious about whether or not you felt that during your interaction with the students, you were actually improving the debriefing skills of the preceptors, because the preceptors might have been eavesdropping or actually standing there with you. So did you feel like that was having another byproduct of developing the preceptor themselves?
Definitely. If you look at kind of what supports learning, if we go back to that Siggins Miller Consultants kind of article that you actually posted in the chat there, the first part is a culture of quality and comprising of relationships, learning, and best practice. And what we found in the research when we were looking at the data, and we actually interviewed paramedics as well. So we had the focus groups with students and then kind of semi-structured interviews with paramedics. We found the paramedics gravitated towards the role modeling of the facilitator as well, because what the facilitator did, the model did, is show the standards of education to kind of paramedics or preceptors. So they started to then emulate that behavior as well, and those attitudes towards students because of that kind of it became a culture. And they also said like, oh, we know someone is kind of passively monitoring how students are going, and then an extension of that is how I behave with the students as well. So it kind of started to change that culture around that. And we did find when there's, say, the facilitator wasn't around, the students still mentioned that the preceptor provided more educational opportunities because they felt like they had confidence in running a simulation and then the debrief and stuff like that as well.
What a great way to potentiate, to inject with a small amount of intervention. You have such a benefit over many years, because those preceptors will get other students and they'll feel valued and they'll feel part of the system. Did you feel like the preceptors were more free afterwards to call you with issues they were having with those students?
Oh, definitely. Like prior to doing this intervention and then afterwards, I would not have had the kind of contact with preceptors as normal. So when we come into the facilitator model, I was getting phone calls all the time, or about either student welfare or like, hey, I'm not sure about the student's level of learning. Can I have a conversation to you? And then they'd be like, oh, this is only their first placement or second placement now. It's like, oh, that makes sense, because I was able to put the context of the student's development based on the curriculum in the kind of minds of the preceptor as well. So they were able to understand the expectations students needed based on that. And that was from a lot of one-on-one work or informal phone calls. But a lot of the phone calls I received were for the facilitator stuff was usually about student welfare. So your student's been to this particular job. Unfortunately, a student was assaulted, I think, in one of these throughout the trial. And then there was also the educational questions. Or then there was a management side, be like, oh, this person's booked off, or I've had to move, like this paramedic had to move stations to fill a roster hole. Is it all right if the student comes along? So be like, yeah, that's fine. Or I'd work with the ambulance management to kind of shimmy the roster a bit, so we had continuity of preceptor as well. So that's the kind of contact we had, not with the students, but with the kind of organisation and the facilitator with the preceptor, but also managers to think about the students and being student focused.
Sure, I love it. I'm curious, because here we have accreditation standards that have a requirement for preceptor training. Do you have required preceptor training? So a student going on roster with on road with a preceptor, does that preceptor have to be pre-selected? In other words, identified and having had training, or it's pretty much in some of our previous iterations of paramedic education, you just show up and whoever's there says, oh, you're riding along. Okay, well, jump in.
It's the latter. There's an expectation, if you're a registered paramedic or even a registered health profession, that you have not the ability, you have some teaching aspect to your role, and that's providing feedback and guidance to up-and-coming paramedics as well. So there's no select training for a preceptor, and it's more the latter that you said there, Dave. It's kind of potluck who you get as out there, and that's due to a whole lot of different system factors. But number one is there is a lot of undergraduate students in Australia, and we wouldn't be able to train as many preceptors to facilitate all those undergraduates in Australia. So it's just it's kind of a roll of the dice which preceptor you do get.
It's fascinating to me. We have the same problem, so we're more similar than we are apart. We have in air quotes too many students, although when you look around, ambulances don't always have students. People understand on the roster, this person's going to be nice to a student, let's put them with this person, because if they go on the roster with this other person, they're going to have a terrible experience. And we don't want to have students who clone bad behaviors from paramedics that we're trying to, coach. And so there's just a very informal way. I hope somebody will do an anthropological ethnography about how it is that that you match make, because I served this role for about 23 years in my previous hat in my old institution, and it's matchmaking. You know
Yes.
that this preceptor needs this, and this student needs this, and
Yes.
so you're going to match the students up to improve the preceptor and improve the student. And if you put people who are too incompatible together, you're just creating a headache for yourself. So you can't, and of course, with tons of students, you have some preceptors who love having students and they'd have one every shift, versus the one that, you put them with just one single shift, and you'll experience bullying, you'll experience hazing. And so I do think that it's in our national education standards, as it is in the Australian registration standards, that all paramedics should be teachers. But let's agree that the principle of teaching a patient about their own health is very different than taking an interest in how to truly facilitate education, and not everyone is actually suited to it or wants it, or on any given day is willing to do it. So I do find it fascinating that you're sort of informally creating a network of people who will be supportive to your students. And it's brilliant that that you wrote this up in a research project. I have a question here, a scientific question about your methods, because I am in the middle of doctoral studies as well, and I'm super curious about the method you use for analysis. But I think it's amazing that a lot of us try things, and you went the next step to actually get IRB approval, get ethics, get the data collected. So I just can't thank you enough and congratulate you for actually taking a formal route that shared this with all of us. Tell me a little bit about Braun and Clark and how their 6-step method of analysis here, the thematic analysis that you did, was helpful to you. Can you explain that to the audience that may not be familiar, on what did you do with these interview transcripts and these words you had to make sense of?
Yeah, no problem. So when you're dealing with qualitative data, obviously you've got a rich source of material, and this was interviews that were transcribed. So we had pages upon pages of discussions among the participants, being the focus group, answering questions. And so we needed a method, or kind of a methodology as well, to kind of analyze that and emerge that. And within qualitative studies, you have different theoretical or philosophical backgrounds to interpret the qualitative data. So you could have gone down the grounded theory perspective, phenomenology. Given the scope and the size of the study, and also at the time the researchers level of competence with, say, qualitative study, we chose a thematic analysis, which you identified was that kind of Braun and Clark 6-phase process. With that, and the first kind of phase is part of you just reading the transcripts and rereading, so familiarizing yourself with that. And we had two researchers, myself and James Pearce, independently doing thematic analysis. That way we were able to kind of triangulate, because once again, you got to note that when you do qualitative research as well, the research is actually kind of parts of the research and brings their own interpretations of data. So everyone's got cognitive frames, which is created by experiences and culture, and interprets data quite differently. So if you can kind of have more than one researcher, say, looking at themes and codes and stuff like that, it just helps triangulate that and break down any of those interpretations that occur just in one mind, just having two minds. So we both familiarized ourselves with the data, and then we started to code the data. So that's where you kind of just look for similar patterns and similar words or similar phrases, and start to identify and code that. And there's different ways you can code. You can code with kind of qualitative programs. You can code by using different colors when you're going through a transcript, or you kind of start to cut up the transcript and move the pieces about into general areas that have particular themes, and you start to see these patterns and themes start to emerge from this qualitative data, and you start lumping them together in overarching themes as well. So does that help answer your question there, Dave?
Yes, love it. You know, a lot of times, and Alex Tremblay, who's really going through quite a day today. He wishes he was here with us. I'll explain in a little bit, but he's bringing up a good point about quantitative versus qualitative. Our healthcare world is so heavy on numbers and counting things, and here you're coding, in air quotes. You're really actually using those methods, whether it's highlighting or assigning them to a theme, to understand what it is that people are saying. And in qualitative data, you don't need 100 people. You might interview 15, although you could have 100. It's not impossible. It's just the way that you code things. But it's wonderful to hear that you've used that method. It's a framework for other people that can just follow the recipe, because we talk a lot about teaching people how to do research on the PCRF podcast, and here there's kind of a ready-made recipe to follow to say, okay, you know, how do you then triangulate is another word that gets used a lot to say, I'm going to check with my other researcher, I'm going to check with the original transcript and see if those things match. So nice. Well, I think we better get to results and conclusions here, because we're running out of time, right?
Yeah. Well, the three.
I'm having so much fun with Liam. I don't want him to go to sleep. No nap for Liam. Sorry.
Well, Liam brought up the three common themes, right? Increased educational opportunities, greater student support and welfare, and improved clinical placement management. And I think the two, improved clinical placement management and greater student support and welfare, were probably expected, because, you know, for obvious reasons, that's what you're doing. You're out there and you're managing the clinical placement, and you're out there to support the students. So those two didn't surprise me, but just getting the increased educational opportunities, I think that's a real tell. And did you find that in both preceptor and focus groups of paramedics, the interviews with preceptors and focus groups with paramedic students?
Yeah, we did. So we found with the students that one, just having someone, I guess, in their corner provided just them with confidence about experimenting within the kind of field, and not being, say, I guess, embarrassed to try stuff with, compared to someone that they don't know. It's you're a bit more standoffish, so that they're able to kind of be able to put themselves out there and actually put themselves in experiences, and then we can use those experiences for reflections as well. The other kind of side of it was we would send the preceptors that we identified based on the roster an email beforehand, and part of that email is like, hey, you've got Megan today as a student. She's a second year. She's covered these subjects. She's just finished, say, cardiology. Here's some scenarios that would aid her if you get time to sit down, because there's a lot of sometimes downtime as well in student placements, and it's kind of time potentially wasted. So we were looking at front-loading preceptors with conversational pieces and background knowledge and some tools.
Yes,
exactly.
Yes.
Tools to use, so that kind of increased that educational opportunity. And then also what that did is start to build team relationships as well, and a lot of this stuff is relationship based, and how comfortable both parties, as in the preceptor and the student, feel with each other. And then if you're in a more comfortable relationship or have a better rapport between preceptor and student, you're more likely that there's trust, and the preceptor is going to provide increased educational opportunities to be like, okay, I know where you're at within your program, so this case is suitable for you. It's at your level. So it allowed that type of aspect of opportunities.
Yeah, I think the educational tools piece is critical, because you hear common, across preceptors, your common, critiques of students where they're very generic and not very specific. Things like, well, we just need to run more calls. The person just needs to run more calls and get more organized. That's the solution is, well, they'll get their organized assessment if we run more calls. Well, and some of that is just not realizing that there are educational tools to get a person there that don't involve waiting for that next big call to come. And so I think that's a really important piece of it, is providing those tools that maybe it's great that the preceptors that you had were receptive to that. Although I did notice that you had a lot of preceptors that said we don't want to participate. So, there's some selection issues here too, right?
It's interesting. So the participation we found was more from the preceptors, unfortunately, being an operational role, and the times for us to conduct interviews. And I think we unfortunately probably did put that in the limitations, was not as conducive as we would have thought for them to actually come out to the university and sit down for an hour or 2 hours and speak. So that was a barrier to doing that. So we only had about 3 preceptors who came along and able to, but they still probably had selection bias associated with that. Coming back to that question is, did the facilitator get pushback? And the question is, yes, there was some paramedics out there when the email was sent. There's basically, would they make up some particular excuse not to have a student, and some of them were quite valid, and some of the excuses, in knowing some of these kind of paramedics, is just like, I know you just don't want a student as well. So there was still some resistance, but that was only a small portion of preceptors that was found as well. So, coming back, I was going to say, double back, one of the slight limitations of this study, or that we could have done, is a content analysis or even a thematic analysis of the facilitator paperwork. So what we made sure was the facilitator kept like a running diary, both for quality assurance, in the sense of understanding what the facilitator, because it was a bit slightly action researchy as well, because it's participant researcher kind of domain, is we just had to keep a diary of what was occurring and some of any kind of issues that arose as well. So and then we also kept like a log of the actions a facilitator did, and given the size of the paper, it's probably its own paper in itself, as a content analysis of that logbook as well, to kind of, probably that would help reinforce the model, or show different aspects of the role of the facilitator there. But coming back to that, those logs would probably show at times some resistance from particular preceptors,
and maybe some evolution over time too, from resistance to acceptance or something, or vice versa. Who knows? We do have a couple quick questions because we're getting to the top of the hour, but some folks out here, I think Cherie, I think, is one of the questions, had asked about, has COVID hindered the ability for facilitators to go riding along out here? And then someone else asks, were they compensated? Are the facilitators compensated?
Yep. So Australia is in a very fortunate role where we're a big island with sparse population, and we really had a kind of hard border principle. COVID did have issues with our clinical placement. They actually stopped student clinical placement for a number of months. And especially when we had a second wave, we had a protracted period of having no clinical placement, and obviously you'd have no preceptor or facilitator because no clinical placement. And we're still catching up on 2020 placements, and we'll probably having to push 2021 placements into 2022. So it's had a big impact on their kind of work integrated or field experience learning of paramedic programs in Australia. The facilitator this kind of project hasn't continued on, and if we get some time, I'll talk about those kind of varying reasons as well. But coming back to the compensation question, yes, the facilitator will be compensated like other facilitators and other disciplines. It's someone who's employed by the university, and that's either through a contract relationship with the ambulance service or a direct employment with the university, and they get compensated financially, and it's reasonable financial, because you got to think about it, they got to be clinically current, but also they got to be educational experts. So you want to create incentives for finding the best people for these type of roles, because it is, if you have a look at it, it's got a management role and a supervisor role, as well as educational and some clinical focus. So you need someone who has those broader managerial leadership, people type skills as well, I believe, for this role.
Great. Well, thank you so much. I look forward to the next level. I'm sure you're going to continue. So,
yes.
and thank you.
That's
and congratulations.
Important. Such important.
And hi, everybody. This is Alex Tremblay.
Hi, Alex. There he is.
Parked. Yeah. we were very safely driving. I was in the passenger seat. So
okay, good.
But Liam, one thing that we're just getting to the root of here in Minnesota is using automated intelligence natural language processing for qualitative research. So what we're in the process of doing right now is entering every chart for trauma patients into this natural language processing software to look for specific words or phrases that people use that maybe identified a more critical patient compared to just how they transported or what interventions that they did, or to see if there's kind of a guiding philosophy that paramedics have around documenting critical patient exams. I think that would be a really terrific opportunity for people looking to do qualitative research in the future, because as Dave pointed out, that it can be very challenging, and kudos to you guys for doing it the way that you did, and maybe some future future consideration with natural language processing.
Oh, that sounds fascinating, Alex, and I'd like to see what arises out of that. But there is, like you're saying, there is some programs I'm starting to familiarize myself with NVivo a lot more, where you're running those transcripts through and looking for those themes, and it actually does that naturally. And that's how we reviewed our new paramedic curriculum, actually, that starts on Monday. Is we looked at all the student evaluations by putting them through a language software program to identify what was good about the program or what we needed to kind of update based on like 5-6 years of student evaluations with the qualitative text as well. So it's very powerful qualitative research, and then some of the software programs behind it to actually generate things from large amounts of data and transcripts. So if anyone's inclined down that way, I'd say don't discount qualitative research to provide the evidence that you need.
Absolutely.
Well, yeah, what great suggestions. And I'm glad Alex is now on voice. As we conclude this, because we really actually are over time, I just want to take a minute. This speaks to the impact that preceptors, educators have on their students. And today's a special day. It's very unfortunate to have to make this announcement on the air like this, but Bruce Cotval, 25 years with North Ambulance and Alina and Lifelink here in Minnesota, has died. And he was actually Alex's FTO, field training officer, preceptor. And those impacts are so profound, and it's so important to remember all of those who served and who really through their work have influenced so many others. So I just wanted to take a minute to give a send-off to Bruce. And Alex, I don't know if you want to say something. I know it's going to be hard, but just remembering him.
I think you covered about everything that I would say. I was a 18-year-old EMT that got hired as a wheelchair van driver at North Ambulance, where I still work today, many years later. I'm not going to say how many. And I thought I had the world figured out and that I was going to make a difference from the front of a wheelchair van. And he was never a jerk to anybody. He was always nice to everybody. And his only requirement for shift was that we would go to a pizza place in Coon Rapids, which is nowhere near where we work. And it was good. And the EMS world needs more kind-hearted people, and this is one less. So,
well, thank you for sharing that. And with Megan's okay, I think today we can dedicate the podcast to him.
That's wonderful, and thank you to all the preceptors out there, and thank you to Bruce. Just a moment of silence. So thank you everyone out there for joining us today, all you educators. A special thanks to Liam, who can go back to sleep now. Good night, Liam. Or good day.
Thank you very much. I think I've had my coffee, so I'm up for the rest of the day.
Yes, great. And thank you, Katie O'Connor, for live streaming this on Facebook. Alex, Dave, everybody out there, thanks for everything that you do. Join us again at the PCRF Education Research Podcast on March 26th. Remember, it's always the fourth Friday at 10 a.m. Pacific, noon Central. The next PCRF Clinical Podcast is Monday, March 8th. So don't forget, that's also at 10 a.m. Pacific, noon Central. If you want to present an upcoming article, please email David Page at dpage@emsed.net. Thank you all.